Afternoon, everybody. It is January the 20th, 2022, and it is time for another weekly episode of THCB Gang. I'm your host, Matthew Holt, the founder and publisher of the healthcare blog at Bolteby on the Twitters, and I have a great lineup today. Last week was the old white men lineup. I'm the only old white man on this one to change things up a little bit. I think I'm now. I won't ask about Casey, but I think I'm the one of the older ones from this one, whereas last week I was the youngest. So doesn't often happen to me these days in my late 50s. Who do I have? I have Casey Quinlan from Healthcare His Hilarious podcast at Mighty Casey. Jennifer Benz from Siegel Benz, at Jen Benz on Twitter. Jean-Luc Neptune, CEO of Suntra Modern Recovery at Jean-Luc Neptune on Twitter. And Fard Johnmar from the digital health consulting house Inspectos at Fard J on Twitter. So that's who the lineup is. Let's find out how everybody is, how everyone's doing. Apparently I look like David Letterman because I definitely need a haircut. That'll happen soon. I'll see if I can show your
Letterman's beard's way bigger than yours, so it's it's okay.
It's okay, we'll see. All right, his beard has got a bit out of control since he got rid of the day job or the night job, whatever it is. All right, so let's start off by figuring out what people have been looking at. I have one funny incident which I will get to at the end of the go round this week. Which hopefully will be, hopefully I'm the only one who's picked it up, but it's pretty damning. So why don't we start off with you, Jen?
Well, Happy New Year, everyone, if I can still say that on January 20th. Nice to be here. Nice to see you all. In addition to still just trying to get back in the swing of things at the start of the year in such a crazy COVID Omicron time, my team has been in a flurry trying to help our clients comply with the No Surprises Act and then get people to understand the over-the-counter coverage for COVID tests. And if you need two better illustrations of how overly complicated the healthcare system is, those are two great ones. Something that seems so simple as how are we going to cover at-home COVID tests takes so much to pull off. It's just absolutely outrageous. So that's of course top of mind. And then all of how employers are reacting to the employer mandate changes and so forth. It's just a little bit of a feeling like a scramble right now and very in the weeds.
Right. Well, I'd love to dig into that because the surprise billing stuff is interesting. Employers getting involved in this and stuff that's been going on there, and I had my own little experience last week of writing about my billing experience at One Medical, which was amusing, chasing down a $7.95, $7, not $795 bill. But when you say employer mandate, are you talking about the vaccine mandate or
the vaccine? Yeah, the vaccine mandate and how that keeps shifting around. Of course, we know what the Supreme Court did, but that's not stopping a lot of employers from going down the path of requiring vaccines or requiring boosters, and you see different headlines all the time. And it's just such a messy area for everyone to try to navigate at the moment.
Absolutely. JL, what have you been up to? What are you looking at?
So my focus has been on COVID testing. And in general, I have to say I've been very impressed by the launch of covidtest.gov. I actually set a calendar item to order my test on Wednesday. And then I saw on social media that the site was open on Tuesday. So I ordered my test. It literally took like 15 seconds to get the test ordered. So I'm excited to be able to start testing more at home. We have a kid in school, a 12-year-old, 7th grade, who's been bringing tests home. So we've been doing a lot more testing. And honestly, if we had been able to do more testing from the onset of the pandemic, I think we'd be in a much better place than we are now. But at least we're able to have that capacity. And I'd say compared to the launch of healthcare.gov, and for those of us on the call probably all remember how much of a disaster that was, it was just a pleasure to land on this website, to be able to get the information that I wanted and to be done with it and have confidence that there was going to be a positive result.
And a little bit simpler though, but nonetheless,
Andy
Slapper isn't needed to come in and rescue this one, or is it Todd Bark?
Todd Bark.
Whoever did it.
Right.
Casey.
Yeah, well, I'm going to springboard off of everything so far and say that from the N of one perspective, I have myself gotten a lovely 2022 little gift in the first week of the year. I went and that one time I went to an event locally, a tech industry event, and took my mask off to eat lunch and left it off because I'm a moron. And yeah, that Sunday, day zero was day zero. And then, of course, because hilariously, I'm me, when I went to get PCR tested, the urgent care where I went hooked me up with a clinical trial for monoclonal antibodies. So the following day, I got shot up with Regeneron because the trial is not blinded, but it is randomized. So I got Regeneron, and I'm getting paid. I'm getting followed. It's an NIH trial. It's like, okay, sure, but so there's been that, and then but because I'm an old, which Matthew referred to at the top here, I am officially an old, so I'm covered by, classic fee-for-service Medicare. So not only am I saving taxpayers lots of money by being in this clinical trial, because no one's getting billed for that Regeneron, at least not directly for caring for old me here. So, all of that was hilarious. And then on the flip side, what I noticed today is, I think this is a joke, I think I figured out what the problem is. A combination of a tweet from a Wharton business school professor. I asked Wharton students what they thought the average American worker makes per year, and 25% of them thought that it was over six figures. One of them thought that it was $800,000 a year. Really not sure what to make of this. The real number is $45,000 a year. Now, well, it's like, hello, welcome. Well, it's Wharton. I had my own thoughts, which I shared on Twitter. People can go over and see that. But then also simultaneously, I'm getting emails about the current hospital crisis where there are no hospital beds, and particularly in rural areas. And hello, thank you, private equity, who went on a buying spree in the previous decade and bought up a whole bunch of hospitals, particularly out in the rural areas of the country, and then sold the land that the hospital stood on, so that the hospital, which previously had owned the land that it sat on, now had to pay whomever rent for their hospital building, and ended up not being able to actually care for people much anymore. And then, the private equity thing in healthcare, it's like, what could go wrong? Well, there you go. So I think I figured out the problem. Kidding.
Okay, if we happen to have a Wharton MBA on the panel, we could possibly ask him what he might think. Why are you hiding behind your hand there?
In general,
the average MBA, I guarantee you, the average Wharton MBA, at least when he worked for me, made at least $800,000 a year, if not more. Wasn't that right?
Whenever I wake up, and I always look at my Twitter trending topics, and if I see Wharton trending, it's always bad, right? It's like never good, whether it's Trump related. In this case, it's just never good. So, I was not excited to see Wharton in the news today.
All right. Fard, it's great to have you back. It's been a while since you've been on the gang. What have you been up to, and what are you looking at?
Yeah, so pinging off what some other people have talked about, I've been actually very concerned and looking at the healthcare professional, the physician crisis that we're in. My feeling is that they're at the front lines, and there's so much burnout and so many people quitting. We were going to have a physician shortage anyway, a nurse shortage anyway, and now that's just exacerbated. So that's number one. I think number two is around how we're going to deal with COVID long term, and what all the various experiments that are happening across the country, and what that means also in terms of people's confidence about vaccines, given the fact that we have a situation where a lot of people are getting COVID that were double vaxxed and boosted, and everybody's asking, well, why? What purpose was that? What reason was for that? And the best answer I saw was actually in the press conference that you may have remembered from the White House press secretary talking about the benefits of vaccination in terms of it kind of gives you a Kevlar vest where you're protected from dying from a bullet, but it's still going to hurt. And that was the best message that I did see, and that's actually one that I've communicated to people that have said, what's the point of all this? Vaccines and boosters and all that. So I think, that's something I've been thinking about, and especially how it impacts the physician workforce, especially and the nurse workforce. From a technological perspective, obviously, I'm waiting to see how the economy influences a lot of the VC activity that we've been seeing in last year in digital health, and whether or not that's going to be slowed down now that the landscape is changing from an economic perspective, now that we have so much non-transient inflation. So those are things I've been thinking about.
Plenty going on there. Well, I will stay on the vaccine one, because I thought yesterday's news was quite remarkable that the county health officer for Orange County, Florida, which I think is where Orlando is, was put on leave because he didn't insist, but suggested to his staff that they should be vaccinated. And that apparently is, I don't know, of all the crazy shit I've seen in the last, 5 years, I think that is the craziest. Now, apparently the official position of the state of Florida is that you shouldn't take a vaccine because presumably Joe Biden.
No, I mean, DeSantis is saying don't get vaccinated. Meanwhile, he's vaccinated and boosted, but
Yeah, I mean, worth saying, Casey, that I had the nanny who looks after my kids got COVID over New Year's, was with us for 3 days before she found out that she'd been exposed. Did have a positive test, isolated for 5 days away from us while what was going on. And our kids who have been vaccinated and I don't know when you were boosted, because you were probably boosted quite early. Our kids who were vaccinated.
I was boosted August 17th, 2021.
So I think there's something going on there, because we were exposed, therefore, to her for 3, 4, 5 days. And yet we've been boosted me and my wife have been boosted in early December, and the kids have been vaccinated around the same time. And it's fresh enough that, a month out, and if those resistance levels clearly drop. But I mean, Fard is right. The best thing we can say with the vaccines now is that if you're boosted, it's still incredibly effective against severe disease.
I will say, and this is, yes, anecdotal evidence, but it's a data point. My experience as a stage 4 cancer patient with an already jacked immune system anyway, and I'm an old, but because I am a, big follower and, got myself vaccinated before I started cancer treatment last year. And then after I crawled from my grave in June, I got boosted as soon as I possibly could in August. My symptoms were that for 2 whole days I had cold. It was annoying. Literally, that's it. And I mean, it's like I'm singing the hosannas of science. It's like, thanks, guys, because otherwise I could very easily have ended up back in the hospital where I was last June, but not with COVID. Right. And, it's like I just my biggest issue with this is that that I got it, self-inflicted wound. That's on me to a degree, but also that it has been so low impact on me overall health-wise, despite the fact that it's still raging out there. I'm lucky.
Yeah, I think that's true. So, Jen, can we dig in here a bit about what the wider scene around vaccine mandates is, what you're hearing, where they are in to take up both points. Casey's saying, look, it did a great job. It worked. It did what it was supposed to do. Fard saying we're hearing a lot of hesitation about that. How is it playing out, and how many in post Supreme Court decision are companies going to be able to enforce the mandates that the ones who already said they're going to do it? And where's this all going to end up?
Yeah. I mean, where it's going to end up, your guess is as good as mine. But there are still many
employers here. I won't accept that.
Many companies. Yeah, many companies are still enforcing the vaccine mandates, and there are a handful that have either tied it to employment eligibility. I mean, quite a few who've just said it's a requirement for employment, and then others that have tied it to healthcare premiums. So you saw the headlines about Kroger charging people more if they're unvaccinated, and then that ties really well to the data that's been coming out about how much more money it costs to be unvaccinated and get COVID. And there was the Peterson Kaiser Family Foundation that's been tracking it, and the headline, I think it was just late last week, was that only from June to November last year, so pretty short period of time, the preventable hospitalizations among unvaccinated was $13 billion. So that's a chunk of change, and we know that employers are covering a big portion of that. So, yeah, I mean, it's a tremendous moving target, and it's going to be very interesting to see how that comes together.
I mean, the other question for and anyone jump in, but I'm also a bit worried that politically there seems to be less and less interest. We had obviously the Virginia elections last year. We discussed the Virginia election last year. We discussed, I know you live there, Casey. I see you making the happy dance about that. I mean, and clearly there was a lot of stuff wrapped up in that with all the BS about critical race theory and a bunch of lies were told. But there was clearly some frustration amongst parents about school closures. We know that's an issue. That can, Biden was on his press conference yesterday saying only 5% of schools are still closed, which is remarkably low. There's a back and forth. In the UK, they just took away masks. They actually were not wearing masks in school for most of the pandemic in the UK. As far as I can tell, in Marin County, all the kids are wearing masks and don't seem to complain about it where I live, but whatever.
Yeah.
However, you do have these ridiculous things like the thing picked up in Florida where DeSantis, despite the fact he's vaccinated, is telling people not to do it and forcing, putting people on leave who are suggesting it's a good idea. On the other hand, I don't see, you have opinion polls saying that Biden's ratings are down in the 40s, and we have the issue of he's got to focus on what the hell Putin is doing in the Ukraine and all this other stuff. Do we think we're kind of done as a society with this? I mean, it's not done with us, but are we kind of done with it? And then what does that mean in terms of is there any chance of getting our boosters and our vaccination rates up? JL?
So I've had this discussion with many people. I think, and in a previous THCP gang, Matthew, I mentioned this. I think that the progression of the pandemic is going to continue to be a regional phenomenon, a county by county process. I think that in places where you have very high vaccination rates, right, which are going to tend to be your more rural areas, your more progressive areas, I definitely have a feeling like we're in a COVID endgame. Now, again, who knows if there's another variant that comes out, another Delta, another Omicron, but I just have a feeling that now in New York, people don't, the school's chancellor has committed to keeping the kids in school. I think that, in most places where you are around, where you're interacting with people want to be back out. And I think what we're going to see in highly vaccinated areas, we're going to say, we've hit an asymptote in terms of the number of people that we can get vaccinated. These public health measures create more costs than benefits. And I think that as we get out of our apartments in places like New York and San Francisco and other places, I think you're going to see a more normal life in the spring. I think you'll probably see the maintenance of masking probably to some extent, but even you may see masking requirements go away. That's what I think. Again, I think we're in the end game in highly vaccinated places. But in other parts of the country, right, that are less progressive, that have been more resistant to vaccination, I think you're going to continue to see the pandemic burning, because although Omicron is allegedly more mild, there is really no evidence that it's reducing the number of people who are ending up in the hospital, in the ICU, if they are unvaccinated. And I think that you actually may start to see in red states and in other lower vaccine places, the return to masking, shutdowns, and other things as the pandemic burns throughout these areas where people are still not vaccinated enough to have a herd-like type of immunity. So that's my bet. But again, if you would have asked me pre-Delta, pre-Omicron, I would have said something and I would have been proven wrong. So who knows what the future brings.
Do you think politically, maybe Fard and Casey, you want to jump in, do you politically that the states where there are low vaccine, go back to Florida again, seem to be the ones where the political leadership has initially has no interest in masking and no interest in aggressively pushing vaccines. Now it seems to be like aggressively anti those things, which work. I mean, I don't know if it seems to me that I agree with you up until your suggestion that they may go back to it. I don't know what the hell happens in those states.
I honestly don't think that they will, because this has become a tribal display. This at this point, I think we're going to have to just, and when I say we, I mean everybody who's involved in the health communication business at all, doing anything, is going to just have to say, okay, these are the facts. This is what is happening. If you choose to ignore this, that's on you. And I mean, sadly, that means that I personally will not be traveling to either Florida or Texas anytime in the foreseeable future, just because I don't feel like exposing myself to that level of stupid. And why on earth would I want to spend any money to support idiots? So, but literally, I mean, I'm not gonna, I have a lot of friends who live in Florida and in Texas, but if we're gonna see each other, it ain't gonna be on their home ground. Just saying. And now, I mean, my state is now, our governor is now in the ranks of people who want to see an elimination of vaccine and mask rules. It's like, oh no, we're just going to ignore all of this. There's pushback happening at the local level, county, city-wide, saying, no, we're going to ignore you. Because he wrote an executive order about no mask mandates and no vaccine mandates. And there are local school boards that are saying, nah, we're not going to pay any attention to you. Come for us. Go ahead. But then there are other areas that are like, oh, yeah, great. Well, we'll just see how that plays out.
And Matthew, I should have clarified. What I should have said is, I think that in areas that have, been less likely, people have been less likely to be vaccinated as they move to return to, let's say, a more normal life or whatever that is, or how they define it. What they're going to bump up against is this constraint, which has always been the healthcare system's capacity, right? And if you could even make the argument that really the whole time that we've been managing this pandemic has always been titrating the progression of the virus through the population to the extent that the health system could sustain that, right? And again, I think like in New York, if you said, hey, everybody, no masks, no social distancing, we're vaccinated enough that our hospitals will not be overwhelmed. My question is, like, I was reading about Oklahoma City, right? Very red state, probably one of the lower levels of vaccination. Their hospitals are overwhelmed, and I think that that's going to continue to be the issue. At some point, you can be as dogmatic as you want. You can be as dogmatic as DeSantis is, but you only have so many doctors, so many hospitals, so many nurses, and so many beds. And if people are getting so sick that they're overwhelming your medical capacity, you probably have to do something about that. I think, but I could be wrong.
And
let's
Darwin.
I'm sorry.
We're all talking. Can I go to Fard, who raised this initially, and then Jen, and then Casey? So do that all.
Yeah. So, I think the bottom line is that it's going to be an economic issue for the states that still have COVID raging. So one of the things, for example, JL, you and I both live in New York. When at the beginning of the year, we had a lot of school issues because all of the bus drivers were sick. The cops are sick. The people working in the supermarkets are sick. And so one of the things that happens is that it's not just the healthcare system, but it's also the people that are sick who cannot engage in daily life, and they cannot do their jobs. So if you have teachers that can't teach, if you have police that can't police, if you have doctors that can't doctor, if you have supermarkets that can't serve their patrons, it ultimately becomes such an overwhelming force on the economies and the lifestyles of the people, quality of life of the people that are not engaging in these activities, that ultimately a choice has to be made. Either you get on with doing something about it, or you continue to have these outsized economic and healthcare effects. Because if you can't go to the hospital to get your cancer treatment because the hospital is completely overwhelmed, that starts to have a big impact on your life. So, I think that's certainly something we should be watching as this continues. And now, God forbid, a variant happens in the United States because of these highly unvaccinated areas. That's going to change, I think, a lot of calculus about how people talk about this, because there's going to be some consequences if that should happen.
Jen.
I was going to say almost exactly what Fard just said, which is that the strain on the healthcare system in some of these places is preventing so much non-COVID care from happening that I wonder if that will get to a point that it actually starts to shift people's opinion in some way about what to do about COVID. Because, you know, there's countless stories of heartbreaking stories of people whose families didn't get the emergency care that they needed, or the acute care that they needed, or the long-term care that they needed because of the hospitals being overwhelmed with COVID. And then that has life or death ramifications. So at what point does that start to shift some of the policy and the mindset in the places that have not wanted to take any precautions with COVID? I don't know what that will, if we'll get to that point, or maybe we're already there.
Yeah, I think that there's something to be said for that combination with the staff shortages and the nursing shortage and the burnout of the 2 years now, basically sticking to the healthcare system and saying, congratulations, keep taking it. On the other hand, with the Supreme Court saying you can't do a George Washington style vaccine mandate, and a lot of the red states, people saying we're not going to enforce masks and what have you, and you might end up with saying we're just going to have to live with this, and if you work in healthcare, it's going to suck, and more we're going to burn out. The political sort of backlash against people who aren't vaccinated, it's all very well to say we can have in New York or California, where it's a small percentage. I don't know what you do in these states where it's where the vaccine rates are 30 to 50%, and you saw some of the polling numbers recently saying what would persuade you to take it, and basically nothing. Most of the people who are now saying they're not going to take the vaccine do it. They're on, it's tribal and ideological, as Casey said. And
yeah, they're dug in. They're not shifting. And I mean, I made a joke about Darwin there for a second, but I honestly think that we're going to see some very Darwinian things going on. Not that they're going to be pretty, but both politically and then across the population, there's going to be some real Darwinian stuff going on. And the question is, will our political system or even our population survive it? Stay tuned for updates. I don't have an answer there.
The issue is, though, right? This is not the Black Death. We're not, it's not 3 in every 10 people dying from gastritis thing. We're still in
at least not with the current iterations of the variants.
It will be a hell of a change for that. All right. Well, let's move on to the second point that Jen raised. I want to dig in here a bit, which is this issue of and we talked about this a little bit before we started the show about the craziness of pricing in American healthcare. And for those of you who haven't read it, I wrote a piece about my experience with the Tony One Medical Company, which is has a very nice primary care doctor. I went and saw. I went and had a basic checkup. A bunch of stuff happened. I got a random bill for $7, and I started to go and try and investigate what did they really charge and what was paid for by Blue Cross of Massachusetts, and that was all spread out. And you can go look at that if you haven't seen it on THCB. Got quite a bit of feedback and amusement. But basically, the lesson is no one can tell what the hell the price should be for anything, and it seems to be random as to who can charge what and get away with it, maybe on market power or who knows what. And then in the midst of all this, of course, none of this was surprise. Everyone was in network, so the billing, it wasn't a surprise to me. It was just confusing to me. And obviously, we have this issue where there's a new legislation around surprise billing, which is predominantly out of network people showing up on the bill who weren't expected. So, Jen, you said that this is. I didn't realize this is going to be an issue for employers. So, can you explain why is it an issue for employers, and what are they doing about it, and what are you doing in that and all of that?
Well, a lot of large employers who have third-party administrators and so forth, they just tell whoever's administering their benefits to deal with it. And that's where the compliance is coming in. We also work with a lot of multi-employer benefit funds that are self-administered in some way, and a lot of public sector entities that are self-administered in some way. And in that way, there are some requirements around getting costs online and different accessibility or different access to pieces. But the most important thing, I think, is just from a pure education standpoint, which goes across the board, is to tell people you shouldn't have this experience anymore. And we know that people, even in really good quote really good health plans, still have the issue of getting outrageous bills from time to time, and then trying to figure out how to navigate through all of that. So part of what we're doing is just some of that baseline education of this is not the experience you should have. And if you still do have that, here are the resources to go to and what to do so that people don't feel like they're on their own.
How does that play out in these trusts? Because in the end, right, so somehow, if that bill shows up again, somebody has to go and complain to somebody. So what's the actual process that these trusts and employers and unions are putting in place?
There's a lot of different ways to give that additional support. So some of it comes through the healthcare navigation companies that are already out there. Some of it is going to be through new processes that are put in place. But inevitably, there's going to be a lot of figuring that out as folks get into it. But this has been something that the companies like Health Advocate and a lot of the high touch kind of concierge health navigator companies have done for a long time, is help people figure out what to do when they get that crazy medical bill that they don't understand what happened.
Yeah, I had an experience last year which was akin to this. It was in network, but I realized that there was one thing which I think everyone should know about. I'm spreading the word. There's a somewhat crazy guy called Al Lewis who was started out in the disease management world and later on became a sort of a heretic. Not saying all this health promotion and wellness stuff doesn't work. He started a company called Quizzify, and one of the things that he does, I've seen this, and I knew about this and just unbelievably stupidly forgot and didn't bring it up, but he distributes to his customers and to anyone else who wants this technique for dealing with emergency room charges, because of EMTALA, the emergency room cannot refuse you. So basically what he suggests people do is when they go in the emergency room is when they sign the thing that says we'll pay the fees, cross out the bit saying we'll pay the fees and write in we will pay, he has some legal language for it, but essentially we'll pay 200% of what Medicare pays, and that's it. And they can't refuse you. So when my kid went into the emergency room last year, because of COVID, I couldn't go in with him. Only one parent went in. So his mum went in with him, had his 4 stitches. And I was sitting in the parking lot going, it's just $3,000, it's $4,000, whatever it is, it's going to blow the deductible, A, and B, it'll wipe out my HSA, or I don't know how much is in the HSA because my wife manages that. But I just completely spaced on the fact that, I should run in the room and dealt with the paperwork and done this. But it's been very effective for those people who used it because it's a contract. And once the hospital agrees that, they also have some support in their company to help people. But in general, the company's, the hospital's going to lose if they've accepted you and treated you and you've written this down. They can only charge you twice Medicare, which tends to be, about a fifth of what typical commercial payers pay for emergency room care. But I mean, I'm not sure how, how that obviously is for in-network or out-of-network or what have you. But for the, how is this playing out for the out-of-network people who are showing up? That is going to keep going because there's still a lot of objection there's still a lot of pushback from the AMA and the AHA and others about that, because they see that as essentially being ground down to the payers, the in-network cheapest rates, whatever they think they're doing. There's a lot of, and when I wrote my little piece about One Medical, they seem to be doing pretty well in terms of how much they were getting out of Blue Cross in Massachusetts. My poor chiropractor, as far as I could tell, had to see 5 times the amount of patients in an hour that my primary care doctor had to see to make the same amount of money. So the justification for that, who knows? Anyway, so there's a lot going on there. JL, you started talking, I'd like you to say a bit more about this, about what you're actually doing in terms of drug administration in your day job at Suntra on recovery. Will you tell us a little bit more about what you were saying earlier about what you're doing and how that's impacting on the pricing for your patients?
Good question. So so before we got on the line, we were talking about a medication called Vivitrol. So Vivitrol is a long-acting naltrexone, and it is a pretty revolutionary medication that helps people with opioid use disorder or alcohol use disorder to remain in recovery if that's what they want. And you generally combine it with coaching or therapy or counseling, and it can be very, very effective. Lots of very persuasive research to show that it works. What we were talking about before we got on the call was how much you pay depending on the type of insurance you have. So for instance, if you have a Medicaid plan, you may pay zero. If you have a United Healthcare plan, you might have a $50 copay and a $500 deductible. If you have an Oscar high deductible plan, you might have to pay $5,000 before the insurance kicks in. And the medication generally costs about $1,200 to $1,400 a month just for the medication. So I think it was an illustration of how crazy our system is. I think what we do to help patients is, one, on the administration side, we are a direct pay organization. So we can give the patient a definitive price. We say, you pay us this much, we will deliver this service, and it covers this period of time. So it's a very clear way of communicating to patients. And I think, again, I continue to argue that fee for service, you can never revise, you can never reform a fee for service system. It is fundamentally dysfunctional, and there's nothing that you could ever do in terms of implementing reforms that will fundamentally change the patient experience. It's not until a patient is literally writing a check for a service that they know what they are getting that people start to have more of an experience like they have in a traditional consumer environment. Now, while our service, the injection part of it, we can describe to the patient, this is how much it's going to cost. We still are going through that crazy third-party reimbursement system when it comes to getting the patient the medication. And I can tell you, it is there's a lot of psychological morbidity associated with not knowing like how much you have to pay, right? And, picking up the phone and playing this Russian roulette with your insurer. And again, I think, there are many things that we have to do, right? We have to change the payment system. We have to change the licensure system. We have to change the malpractice system. There are so many things we need to do, but, definitely as it relates to getting your medication, the American system is very complicated, and I don't know if we get any efficiency out of that complexity.
Casey, you've spent a fair amount of time thinking about that in your own life.
Well, I did. I became a self-appointed expert, on the internet, about finding out cash prices for stuff because I was uninsured for 5 years after my first go round with cancer. And there are ways that people can do this for themselves. I applaud what Jean-Luc is doing because they are taking a lot of the sort of the mystery, at least for the people that they're working with, out of how to manage this. But the fact that they still, Jean-Luc and the patients he serves and his company are still having to bear a huge burden of just, administrivia of trying to figure out how to get what you need. And this is, American healthcare system, the payment model writ large is, confusion to mine enemies. In other words, I can continue, I being the healthcare system, all the players, I can now suck up $4 trillion a year because confusion to mine enemies. No one understands how this works. If you ask someone how much something is, no one can answer you. And, it just, the fact that employers, and I mean, this goes directly to, what Jennifer does. And not that I'm trying to knock over her rice bowl, but the fact that employers have to pay for consulting services, such as the great expertise that Jennifer and her, the rest of the people she works with provide. It's like, our system is so broken that no one knows how it works, the payment model. I mean, the actual delivery of care, we've got great doctors, really good hospitals, a lot of different other, physician extenders, nurses, PAs, all of the things. But the payment model that wraps around it is so impenetrable and ununderstandable that we're all crushed under its tank treads all day, every day. We've all told stories about this just today.
Sure.
And, where does the $4 trillion a year go? An awful lot of it goes to this administrative bloat because no one can figure out WTF is going on.
Yeah. So, don't worry. Jen's rice bowl is plenty big. She can have a bit.
Well,
I want to
looking to put anybody out of business.
Yeah.
Sure.
However, there are some people that need to be put out of business.
It's true.
And, we need to identify them, name and shame, and pull the plug. Done.
It's true. I mean, there's so much of what we and many, many, many others have to do to explain the unnecessary complexity of the healthcare system that in a more rational system would just go away because things would actually just work the way that they should work.
But there's no money in it.
And
Yeah.
and as Casey says, many of us will have to go get real jobs in that case. So I want to make a tweak here and take us to take us via somebody I met a lot the other week. So I met somebody who was, I'm blanking on her name, but she was at a company called Sidecar Health, which actually I had the CEO, Patrick Quigley, on my conference last year. And I was very curious when they came out, because it looked like they were kind of like a sharing ministry. And I went, no, that can't be right, because they were selling what they claimed to be legal health plans. And there's been a lot of issues, as we know, around sharing ministries and people not. John Oliver did a whole thing about them and not, in fact, set up his own about them not paying up and the sort of scam that they were. There was a court case about them. But what I found out Sidecar Health is now doing is they're selling, I believe, ACA compliant plans to employers and individuals. But what they're doing is they are producing a price list, which has God knows how many thousand CPD codes or whatever it's got on it. And they're attempting to do the inverse of what so JL is doing from the provider side, which is they're saying, if you go to and they admitted to me there were some complications with inpatient stays and what have you, but if you go to an imaging center, an outpatient clinic, a hospital, whatever, and you find out what your codes are, they will tell you what they as an insurer will pay as their version, like the way they think the cash price is, and then they're expecting you as a member to negotiate or tell the provider you're not going to pay anymore. So that's a kind of interesting approach. I don't know how scalable it is and how well it'll work, but to me, that's like one attempt to like line it up, because if you do that with any other insurer, they can't, as Casey said, they can't do it for you. So I don't know if that's the way around, but basically say, here is how much money I'm coming to the table, how I'm coming to your office and onto the table equipped with, like it or not. And if you don't like it, I'll go down the street to somebody else. And they don't have a network, they just have the amount of cash they're paying per activity. Whether that's doable or not, I don't know. I wanted just to bring them in because they raised some money last year, and I wanted to change our topic a little bit, because that is one of the venture-backed ideas, whether it's the right one. They were on a panel last year with a bunch of people, including someone from Oscar, someone from Bright Health, someone from Capital RX, one of the new PBMs. And all of these folks are many of the many thousands of companies that Fard tracks carefully and I track a little bit less carefully, who are in this sort of digital health world. And I wanted to bring in the thing that's happened, although today, Thursday, life is a little bit better. Over the last 9 months, we've had this incredible situation where the stock of those companies, stocks of those publicly traded digital health companies were incredibly high, basically a year to 9 months ago, and have collapsed by a factor of about 60-70%, depending which ones they are. And yet, every day, Jess and me report, or every week, couple of times a week, Jess and I report on who got funded this week, and it's another 150 million here, an evaluation of 4 billion, another 300 million there, and a valuation of 6 billion. And you're going, how do these two things differentiate between the private markets still going crazy with all that money, and Andreessen Horowitz and Oak and General Catalyst raising new funds daily, as it appears, at billions of dollars, versus what's happening in those public markets. So, Fard, I haven't had your opinion on that. So I'd love you to tell me what you think is going on in the world of venture funding versus those publicly traded digital health companies.
Expectations versus reality.
Do you want to expand on that a bit?
And by the way, that's exactly what I was going to say. But go ahead, Fard.
I think you and I are simpatico about this. The world of venture, it's all about the thesis, and it's all about making bets on companies, and it's all about the narrative, right? And so the narrative is, that digital health is here to stay, and that, a number of these companies will be successful. The companies that are in the public markets, however, have to report revenues and uptake. And so sometimes the numbers are disappointing versus the valuations and the expectations. So it's perception versus reality. This happens in every market. The private markets are, tremendous valuations. And then when they go to the public markets and they have to report out, that's when people start to say, well, this wasn't quite as good an idea as I thought it was going to be when but if you're an early stage investor and you're providing these valuations, when, your liquidity event is when they go public, and then you've done your job, so they're not betting on the long-term success of the company. They're betting on a liquidity event. And that's when they go public. So, that's just the way it works. So I think that's the reason that you see a lot of these valuations in the public markets actually go down, because that air is popped. That air, in terms of expectations, is popped out of the balloon. So, Jay, what were you going to say?
No, I totally agree. I mean, I think, there, and Matthew, I mentioned this pre-pandemic or in an early THCB, pre-pandemic digital health stories, they were getting funded. When I was at Blueprint Health when we enrolled our last class in 2016, if a company raised $3 million, $5 million in a Series A, that was like a big deal. That was a huge victory. And we were, you're talking about the best companies, the most highly selected companies in our space. And, that has changed dramatically in 5 years. Why has that changed? And I think, again, as I mentioned previously, I think the pandemic has made 50-state telemedicine stories palatable and believable to VCs, right? Before, it was hard to sell a concept that you were going to have a women's health company that was going to be able to serve people in all 50 states. Now you have 10 of those companies that have raised, more than $100 million altogether. So I think that's a big part of it. And I still think that VCs are betting on fundamental revolutionary change in the healthcare system. Again, rewind our conversation 15 minutes ago, where we were saying, I was saying that this is a system that cannot be reformed. Well, if it's a system that cannot be reformed, maybe there will be another system that supplants it in the future. And maybe this massive aerial assault that we're seeing from VCs is what's going to help to precipitate a destruction of the established order and bring on some other new order. But I very much agree with what Fard had to say. Is like, now that these companies have to show, what is our membership growth? What is our, average revenue per user per year? Our ARPU. I think it's not that the revolution hasn't happened yet. It hasn't been televised yet. And I think maybe as we go down the line and we've invested $10 billion, $20 billion, $100 billion into the healthcare space, maybe we will see a revolutionary change, but it hasn't happened yet.
Yeah, and I'm hearing Gil Scott Heron in the background as John is talking. But I mean, I've said, somewhat publicly, but, certainly, in private for years, that the only way we're going to fix this giant machine we've built is by destroying it completely and rebuilding from the ground up. And that's not going to happen without some real ugly in between here and there. So I do think that there's a hell of a lot of promise in the emerging models that Jean-Luc just referred to, and the fact that, chinking away at the armor of everything has to be different in 50 states. No, not necessarily. We could maybe change that. And it would just, this sort of chink, chink, chink. I think the whole engine's going to fall apart soon. I don't know exactly when. It's probably going to take, looking from here, I think it's going to take maybe another decade before that whole destruction, reconstruction process, it really takes hold. But it's going to happen. It's just a question of whether or not there are enough forward-thinking, capitalist types, venture capitalists, even hedge funds, who have their heads attached to their hearts somehow, so that it's not just about the balance sheet and only about how much we can squeeze out of this before, we throw it back and, make our money and move on. But, if there's some real mission-driven work there, I think there's some hope. If not, if everybody's just still chasing the $4 trillion a year, we're screwed.
I love the concept of hedge funds having a heart, but there we go.
You never know. I mean, one of my cousins is a big hedge fund guy, and he's not got his head completely cranial rectal inversion problem, but maybe it's just him. I don't know.
We'll find out. So, Jen, I want to come to you about this, because there is, if we accept that, okay, the reason the VCs are pouring in is they'll, the public companies will either recover or they won't. The VCs are, and the private equity funds who are funding a lot of this, the $300 million rounds and plus in some of these companies, it's now past VCs, it's all of us and, pension funds and private equity funds and everywhere else. But a lot of this is dependent on somebody saying, I'm so fed up with the current system that I'm going to buy something different, right? And whenever we have Ian Morrison on the show, he always reminds us that, you know, it's the employers who are paying 4 times what Medicare is paying. Last week, there was a whole discussion with Ian and Jeff where I was trying to say that, no, you know, hospitals could survive on Medicare, and they were telling me they couldn't. And therefore, you know, employers had to pay more and all the rest of it. But if you look at the people, that, you know, who are aggressively doing this, you've got a bunch of new companies. If we talk to, you know, Faye Rotenberg, Jonathan Bush at Firefly Health, they say we're building a new product. It's going to be 50% less, and we're just, you know, winning healthcare for less. You have Dave Chase and his gang of people in the whole Health Rosetta who say we can go somewhere and we can do healthcare for 30 to 40% less if your employees are prepared to, you know, you're prepared to do this to your employees. And yet that stuff, we've heard these stories for a long time, that stuff has not spread. And it's all back to, you know, Ian was always telling me, the PBGH, or what it was called now, is going to do something. Are you hearing that from employers? Are you hearing upset employers, or are they still in such an arms race to keep their employees happy? It doesn't matter. Because I think someone's got to get behind this, and it's going to happen.
Yeah, I think all of that, all of the above, employers are really upset about the amount that healthcare spend keeps going up, but I don't think they necessarily feel that they have all of the tools to totally change it. And it's not just about keeping employees happy; it's just about keeping the businesses running in some cases. And a lot of these concepts require a tremendous amount of new learning and behavior change on the part of the individual healthcare user still. And you know, as we hear the different ideas, I'm just thinking how hard it is for people to change those fundamental behaviors, particularly when we're in such a stressful and uncertain environment anyway. I mean, it was hard to get people to change healthcare or think about fundamental changes to healthcare before the pandemic. Now, with so much uncertainty, I don't think this is the time where a lot of companies are saying, okay, you know, 2022, this is the year that we're going to really throw out this massive behavior change. They're saying we've just got to get people care. We've just got to get them to mental health providers, and we've got to get them to the basic primary care and preventive care that they've been missing out on. So I feel like we're kind of back to some of those just fundamental, basic, are people even accessing care in the current system the way that they should? And some of that big changes is going to get punted a few more years down the road.
Yeah, I mean, I agree. You know, I think the other thing that we tend to forget is not forget, but just maybe not think about as much with regard to work life, is that we're going through a period right now where people are leaving their jobs and doing new things in droves. So I think companies are facing a crisis in terms of retaining the talent that they've cultivated over time. And healthcare, I don't want to call it shenanigans, but machinations are just completely way down the list. Yeah. And so, you know, they're going to bite the bullet with regard to the healthcare costs because they're having to pay their employees, you know, 10, 15% more to just keep them. So I think we're just in a state of flux right now, and I'm just not sure if we're going to see the companies really take the charge on that until it becomes until it becomes such a heavy burden on the balance sheet that they have to do something about it. You know, and they've been able to manage it so that it doesn't become a huge burden on the balance sheet, and then it's just business as usual as long as it doesn't go over a certain threshold. You know, it's not ringing alarm bells, so it's more difficult to make those changes. I'm sure you're seeing that as well, right? Just get it done. It's the last thing I need to worry about.
So I think if I put those two comments together, we're back kind of to where we were. You know, can you manage your company, your county, your city, your area? You know, can you manage the COVID thing? If that goes away enough that we're kind of back to normal. And I talked to you about this before, Jen. You're the one who said, I said, well, why are these people all quitting? And you said these jobs suck. You know, but we get it back to normal where the labor shortage is not the problem it was, and people start coming back in the workforce, and you know, and with perhaps some of the federal subsidies that we're starting to see, you know, go away may push people back in that direction. Do you think it's looking out beyond this, a year and a half, 2 years, we will come back to what Fard said, how bad is it with the balance sheet, and things aren't as good for employers as they have been, that we have another crack at this from the employer angle? Or is that, am I being too optimistic, pessimistic, too aggressive in my forecast?
I think there's always going to be innovation happening in the employer community, and it's just a question of when are things going to line up for that to really push to some fundamentally different systems. I'm very excited and optimistic about two things. One is the amount of attention that direct contracting is getting, and direct contracting paired with a concierge model, so that you just don't send people to those crappy providers and you know what you're paying. And then mental health, we have so much that's being put into mental health care right now, and we're gonna learn a ton in this next year, 18 months, about what works, what doesn't, how to get people engaged, and so forth. And I think that's gonna lead to some better outcomes too. So I'm always an optimist, but fundamentally changing the underpinnings of U.S. healthcare, well, I don't think it's going to happen this year.
Okay, so not in the next 3 months, but eventually, Glenn Tillman at Transparent and the folks at Accolade and everywhere else are going to be more important. I think that's actually true, right? I'm seeing a lot of innovation and investment in companies who are doing things like sending community health workers out to Medicare for Medicaid recipients, and sending people to their homes, and trying to figure out that kind of switching from the hospital and the doctor's office, the place you go and see occasionally, to somewhere where it's more continuous care out in the community. That is starting to pick up, and you're hearing a lot of conversations about social determinants of health and equity and all some good stuff. But as Sachin Jain, what was it, CareMore, and now it's at Scan Health, I know it says there's like the innovation healthcare group, and there's the people on the ground doing stuff, and they don't always communicate very clearly. All right. Well, we have come to very close to the end of another hour that you spent hanging out with us on THCB Gang. And as we do every week, I'm just going to go around the group and ask people what their forecast prediction, what they're up to, what the thing that they think we're all going to be talking about in the next couple of weeks. So I will start with you, Casey.
Well, pivoting off of, sort of where we ended up talking about defenestrating the entire healthcare system and building something new. I don't, that's not going to happen for at least 10 years. I already said that, but I do think that there is a huge opportunity here, as long as we're expecting employers to foot the bill for healthcare coverage for their employees. I think that this move to direct contracting that got mentioned, and that kind of action on the part of employers, particularly big ones, is going to have some serious move toward actually getting a handle on at least how much people are going to end up having to pay, and employees understanding what their exposure is, because that your mileage may vary thing about figuring out how much something's going to cost is a huge weight on a lot of people. And then on the public side, taking care of people who are not advantaged, i.e., the social determinants of health and people who have a lot of negatives on that personal balance sheet of theirs. I think there's a lot of players coming into the space, so using a lot of digital tools and marrying that with actual humans, that I think there's some potential here. So I'm keeping an eye on that.
Right. Well, by the way, that's supposed to be 20 seconds. Casey overdid it. But
So I'm very interested to see what happens once every American has a COVID test in their home, and how does that impact people's behavior, and how does that impact the progression of the pandemic? So I'm very interested to see what's coming out of that. And by the way, a little plug: I am working on a podcast right now with the folks at Offscript Media. It's going to be called Doc, or Is It Serious? And it's going to be a kitchen confidential approach to healthcare that I'm doing with another doctor named Mark Lewis.
I will look forward to that. We'll tell them all about it. Fard, what are you looking at?
So I'm just looking at the progression of COVID. I think there are rumblings that we could enter a new phase where it's kind of like the flu, and we get our shot every year. So people are kind of looking forward to that being the next thing. So I think we'll continue to see some conversation about that. So that's one thing I'm looking at. And of course, continuing to try to understand how these digital solutions are going to be adopted or not adopted as behaviors are changing. I think one of the things that to think about is because we've been in this for 2.5 years now, 2 years, a long time, behaviors are certainly different. And I'd like to understand how those persist over time.
Jen, you get the final word.
I think all those are great, are great. And I think the one thing we've hinted at a little bit, but it's top of mind for me, especially because I have a large team, is not just the burnout in the healthcare system, but the burnout everywhere. And how can we think creatively about work and get people still energized and doing the things that they need to do to take care of themselves in this moment? It's certainly a tough time to be wanting to put all your energy into things and feel like you can do everything that's needed right now.
Well, I want to thank everyone for their energy and their efforts, at least for the last hour. You did a great job. You have been listening to, I'll bring them up here, Casey Quinlan, all the way from Richmond, Virginia. Jen Benz from the hills of San Francisco out the back. I think she's there. It looks a bit cloudy where Jen is. It's possible it might be she might have some ski slopes somewhere. John Neptune and Fard Johnmar, both from New York City. And that was THCB Gang for January the 22nd. I was your host, Matthew Holt. Look forward to seeing everyone next week, January the 27th, or whenever, if you're listening to this on the podcast, which is quite often how I listen to the recap. That's THCB Gang, where we're back with another different set of gang members to figure out what the hell happened in healthcare that week. And with that, we'll say goodbye, and we'll catch you in